Hello, my name is Kelly, and I will be discussing a relative motion orthosis for a sagittal band injury. The sagittal bands are the primary stabilizers of the extensor tendons. They originate from the volar plate and insert into the extensor mechanism while surrounding the MCP head of each finger. The significance of these bands are that they prevent lateral band migration of EDC tendons, prevent ulnar deviation during MCP flexion, and to prevent tendon bowstringing during MCP hyperextension. An injury to our sagittal bands can occur by a direct force to the MCP joint of the finger, could be due to a laceration directly to the extensor hood. It also could be due to forced flexion or extension at the MCP joint of the finger, or sometimes it could be atraumatic, meaning it can happen secondary to rheumatoid arthritis due to its inflammatory response. Goals for this injury, where you are utilizing a relative motion orthosis or not, are to prevent and avoid full composite fist flexion during grasping activities, as well as repetitive wrist flexion. This will allow resting time for the inflamed sagittal band or healing time if it was repaired. Another goal is to prevent an extensor lag, which occurs during a sagittal band injury. Another goal is to prevent tendon adherence. Intrinsic tightness is common with this kind of injury, and intrinsic tightness can cause tendon adherence, especially if the sagittal band is repaired. Finally, the last goal is to avoid PIP joint contractures for improved functional outcomes of the hand. These usually occur, again, due to intrinsic tightness or from delayed treatment non-operatively. Some fabrication considerations that you should consider while you're making this orthosis is the zone of the injury. The zone of the extensor tendon injury will dictate what orthosis you should consider fabricating. An extensor tendon zone 4 is the most common zone for an RMO orthosis or a relative motion orthosis. The surgical technique. The surgical technique, considering the number of strands the surgeon used to repair the tendon, will dictate how long you are having your patient wear the orthosis. The more the strands, the stronger the repair. Timeline. Did the patient come to you early or later postoperatively? This may also dictate how long you have your patient wear the relative motion orthosis. The protocol. Do you have a specific protocol from your surgeon to follow? If not, take the conservative approach and lay more on the cautious side. And finally, education. You always want to educate your patient on the purpose and the significance of wearing the orthosis. You should go over his or her wearing schedule, as well as any current precautions or restrictions. A relative motion extension orthosis holds the involved MCP joint in more extension relative to the adjacent digits, about 15 to 20 degrees. For a sagittal band injury, you should fabricate a relative extension orthosis, which will place the involved finger in more extension than the adjacent digits, allowing resting and healing time for the sagittal band. Other injuries that could benefit from a relative extension orthosis include the person might have PIP joint stiffness, the person might have extensor tendon snapping, trigger finger, or if the individual has limited flexor tendon excursion. A relative motion flexion orthosis holds the involved MCP joint in more flexion relative to the adjacent digits, again about 15 to 20 degrees. Individuals with PIP joint extension lags would benefit from this orthosis because it'll help transmit forces to the PIP joint in extension. This also will allow the individual to work on active isolated PIP joint extension while in the orthosis. Some of the materials needed for this orthosis may include Orthicast. You can use either 1-inch or 2-inch, regular scissors, blunt edge scissors if you have them, a towel, and a heat gun or hot water. First, you want to cut a 1-inch or 2-inch piece of Orthicast. Here I'll be showing you 2-inch, about twice the length of the patient's 4 fingers wide. Heat up the Orthicast material with your heat gun or hot water until the edges of the material curl on both sides. Flip this over and repeat 2 to 3 times on both sides. If needed, you can pull the ends of the orthocast to stretch out the material. Finally, you want to fold the orthocast in half lengthwise, adhering the material together. This double layer will be more supportive for your patient. Place the center of the material under the long finger along the volar aspect of P1. Then you want to wrap the orthocast around the adjacent fingers, which in this case are the ring finger and the index finger, and adhere the two ends together. You should adhere the ends together along the volar aspect of the long finger. Place the long finger in relative extension, approximately 15 to 20 degrees, compared to the adjacent fingers, and hold that position until the material hardens. Make sure the rings for the adjacent fingers are wide enough to accommodate the PIP joints of the fingers so the orthosis can be donned and doffed by your patient. Once the material is hard, ensure the PIP joints are not restricted by the orthosis so the individual can perform isolated PIP joint flexion exercises while wearing the orthosis. Trim the edges and smooth where necessary, and make sure the orthosis is comfortable for your patient. Other considerations while fabricating a relative motion orthosis: your patient's wearing schedule. So we talked about this a little bit earlier, but the patient should really be educated on his or her wearing schedule depending on the involvement of the injury. Most of the time, the individual should be wearing the orthosis at all times, and this is to avoid composite fist flexion and allow healing time, including adjacent digits. Depending on the involved digits of the injury, you will either need to fabricate an orthosis that includes 3 or 4 digits. Avoiding restricting PIP joint motion. After you fabricate the orthosis, you want to ensure that the volar and or dorsal aspect of the PIP joint is cleared for PIP joint motion. So the patient can utilize this orthosis to work on either flexion or extension depending on their injury. Informing your patient to utilize the orthosis for everyday activities as best as they can. While wearing the orthosis, they should use their hand as much as possible for their everyday activities. Checking in with your patient. Check their skin. Make sure the patient is wearing the orthosis correctly and it fits properly. Make sure that there's no adjustments that are needed. Make sure they can don and doff it appropriately. And then lastly, like we discussed earlier, you should be placing the involved finger in approximately 15 to 20 degrees of relative flexion or extension, depending on which orthosis you are fabricating for your patients. If you found this video helpful, please comment below or let me know what orthosis you would like to see. Thank you again for watching. Check out my Instagram page for pictures of orthoses along with these videos.